Well, good afternoon, everyone. It's Bob Vonderheid. I'm the director of the Abramson Cancer Center. We can't thank you enough for spending some time with us this afternoon. How we wish we were in person, as we have been before, but we really appreciate folks joining really from all over the region and all over the country to get an update, talk about breakthroughs, see what's going on with the Breakthrough Bike Challenge and the Abramson Cancer Center. So it's a beautiful day in Philadelphia today, spring, and it really, when we think about the past year, I think we're all happy that we're getting back to normal. I was in the clinic most of this morning, and it's active, it's busy, and despite the challenge of COVID and so many things in this past year, we've kept our head down and focused on our mission and seeing patients and continuing to do research and science, and we can't thank all of you who've partnered with Breakthrough Bike Challenge to support our work. And we're glad you're here today to hear about what's going on. Breakthrough Bike Challenge has been a connector for us. As you know, we throw ourselves into the event as much as other participants, forming networks, forming teams. And even though it was virtual last year, it really was a way to keep morale up and to keep focused on the mission. We thank everyone involved with Breakthrough Bike Challenge for that incredible opportunity, and it's all for good. I'll just go through a few statistics before we get to our speakers today. As you know, 100% of participant-raised funds go directly to support cancer research here at the Abramson Cancer Center, and so all total, BBC has now raised $1.675 million since the first ride in 2013. Absolutely incredible. And what that means is, to date, around 38 faculty members have received financial support for their research ideas. We call these researchers Buzz Cooper Scholars, Buzz Cooper being one of the first Cancer Center directors here. And today you'll hear from 4 of those recipients and get an insight and sort of a look behind the curtain about their work and what's going on. In 2020, as you know, the event was virtual. However, 485 registered participants, which was a record number, bikers, spinners, walkers, and runners, all came together. We raised $275,000, 39 different teams. As I said, an incredible connector. The event this year is September 12th, as you all know. We're still uncertain if there'll be an in-person part of it, but right now we know that the ACC will host a 2-week Design Your Own BBC virtual event, and that begins August 31st, and it'll give an opportunity for our community to join as bikers, spinners, runners, walkers to advance cancer research. Now, a little bit about today. The 2020 Cooper Scholars focused and were selected to focus on a disease that it remains a challenge in many ways, prostate cancer. Prostate cancer is the second leading cause of cancer death in men in the United States. And here in the Philadelphia area, it's actually a particular problem, even compared to the rest of the country. Some people don't know that there's a 25% higher incidence of prostate cancer here in the Delaware Valley than the rest of the country. The problem is particularly pronounced in Philadelphia, where it's more like 40% more common than the rest of the country, and there is great concern about how it adversely affects minority populations, particularly Black men here in Philadelphia. So we're committed to changing that, and there's hope. Many patients diagnosed with prostate cancer are treated and walk away from that. We're focused on how to make that happen more often, to make it happen every time. And for those where prostate cancer comes back or presents beyond the prostate, how can we treat those patients and afford the best quality of life, the best survivorship, and change the outlook? So the Cooper Scholar Program is intended in 2020 on prostate cancer to have real impact. And you know, we have inspiration because BBC board member Jeff Krieger, who is so courageously faced his battle with prostate cancer, doing well, most recently rode his bike through every 39 radiation treatments which amounted to about 1,000 miles. And of course, those treatments were orchestrated by his care team so that he could do that with the sunrise every day. I used to see him coming in, when I was coming into work, I used to see him coming in and see that smile and the determination on his face, really a story of hope. And we're happy Jeff has joined us today, and we say hello. So let's dig in and focus this afternoon on understanding more about prostate cancer and how we're going to make a big difference. We have 3 presentations. The last presentation, two faculty members will present. So we'll just jump right in and I'll introduce our first speaker. What we'll ask you to do is, as you have questions, you can go to the Q&A chat box and put them there. And we're going to hear from all 3 talks, and then we'll open it up for questions, and we'll learn from each other. Okay, so first up is Dr. Crystal Kahn. Dr. Kahn is a relatively new member of the faculty. We were really pleased to recruit her to come to Philadelphia. She joined the Department of Radiation Oncology. She's a basic scientist, PhD, and she is focused on what I was talking about before, those types of prostate cancer that are aggressive, clinically aggressive, and she's come up with a really cool, novel way to address it, and funding from BBC is supporting her work. So, Dr. Kahn, thank you for joining, and the floor is yours.
Work, and more or less the concept that we might be able to remove the brakes in order to treat aggressive prostate cancer. So in general, over the last 2 decades, physicians and researchers have been working in collaboration worldwide. What we're trying to do is understand how cancer evolves and why it becomes, a normal cell to a cancer cell in the first place. And so we do this by mapping the backbone or the instructions of the cells. We look at the genetic alterations and mutations that occur, and we look at the RNA sequencing in order to have the cancer backbone. But what I do is I look at the downstream effects of that, and I look mostly at proteomics and the signaling that is downstream. And so why does proteomics matter for cancer growth? Well, in general, I like to think about it in this kind of scenario. We have our healthy cells, which have the correct blueprint, the right instructions to make all the safety, features able for them for their own individual growth. And so these cells basically see all the warning signs, and they do what is smart and best for the individual. But our cancer cells have altered their blueprint, they've changed their instructions, and they really want to test that. And so what they do is they just slam on the gas. And one of the things that means is that they actually drive up their protein synthesis, and in turn this increases tumor growth. So even though this promotes cancer cells' survival, it actually causes a lot of stress to the actual cells. So our cancer cells will continuously drive up protein synthesis, and they will survive, but they might not thrive in this condition. And so my work over the last 5 years, and more recently now, is really focused on the more aggressive and lethal tumor cells, those that become eventually metastatic. And very similar to our cancer cells, these aggressive cells have a very similar blueprint. They have the same instruction manual, but they've adapted, they've evolved, and they've become more innovative. So they now recognize the warning signs that the normal cancer cells ignore, and what they do is they don't slam on the gas, but they actually reroute their protein synthesis in order to take a more luxury route. And by doing so, this actually decreases the stress of the aggressive tumor cells, and they grow better, they survive longer. And sadly for the patients, what ends up happening is many times these type of cells become metastatic, and in prostate cancer can sometimes become lethal. So having identified that these aggressive cells were not just slamming on the gas to drive up protein synthesis, but were actually rewiring it for their own growth, I had this idea that we might be able to cut the brakes. And what exactly do I mean by that? Well, I don't work in innovative cars. It would be fun if I did, but I work much more at a molecular level. And so I study this by using genetically engineered mouse models that actually mimic what we see in the human prostate cancer. So I have models where we have our primary tumors growing by the same blueprint that we see in our patients. And if I cut the brakes here, you can see the tumor on the left continues to grow because it's not being, pushed. It already was slamming on the gas. But in our aggressive, more lethal tumors, they are much more aggressive from the start. But if I cut the brakes by using small molecules that are like a therapy to treat these tumors, what you actually see is that the tumors regress. So what this meant for us is that somehow these more lethal cells have become reliant on this rewiring of their protein synthesis. And this means in the clinic that we might have a new vulnerability that we can actually target in order to drive up the stress and decrease the tumor size. So again, I don't work on competitive cars or innovative technology at that level, but I work on this all much more at the cellular level. And so my lab, our group, is working to identify aggressive tumors and how they rewire our gene expression by regulating their protein synthesis. And so I'm doing this mostly in cell signaling models and also in tumors that are graciously donated by patients in order to identify, based on the blueprint, what is happening for the adaptive cancer proteome. And so I do this by looking directly at how proteins are made and where they're made. And what we've already identified in just this last year is that there are approximately 30% of proteins that we don't know their function. They are unique protein isoforms that are only happening in the aggressive disease. And so it's my job and the job of us here at Penn in order to identify what the role of these proteins are specifically for this aggressive disease. Furthermore, we're also focusing on looking at the regulatory components and more or less the players that are involved for this adaptive translational response. And altogether, we believe that by combining the blueprint and the effects downstream, including proteomics, we can hopefully come up with better biomarkers and eventually have more therapeutical targets in order to allow us to treat patients with more precise medicine. And with that, I could take any questions for this work.
Thanks, Dr. Khan. It's counterintuitive, right, to think about these tumors tapping the brakes so that they get back on the rails and then they go faster. So when you look now at some of the proteins that are emerging in this network, do you see some that look like we could make a drug against them? Are there any candidates?
So this is very, very new, but there are candidates. For example, we've done this, so I'm just starting to do this in prostate cancer, but we have already seen, for example, PD-L1, which is a major protein that's important for immunotherapy, which you're well aware of. It actually changes where its translation starts so that it can evade basically the tumor cells, and that causes metastases more regularly. So what we could do is we could treat the extension if we could create a small molecule that would only target the unique protein isoform, not the normal protein that healthy cells need. And that would be, a great target directly in aggressive cells and cancer.
Yeah. Well, we're going to come back to more questions after we hear the other speakers, but it's super exciting. It's a new avenue. I think we should just remind folks, this is not a new chemotherapy. This is this will probably, if it works, it'll probably end up being a small molecule, could be a pill, right? This is not a chemotherapy that we remember from 10 or 20 years. Okay, so hang on, stay with us. We'll be back in a minute. Dr. Khan, we're going to move over to another presenter who is Dr. Sam Takvorian. Sam is instructor in medicine in the division of Hem-Onc, focused on taking care of patients with prostate cancer and in particular working on what we call bony health. Big problem in prostate cancer that the tumor will leave the prostate, go to the bones, and once there, it can cause a break. It's a huge issue, and we need to be smarter about it. And Dr. Takvorian is going to tell us about his strategy. So,
I want to thank you all for the opportunity to speak today, and most importantly, for supporting research across the translational spectrum, from bench to bedside, as the saying goes, not only to advance the basic and clinical science, but also to make certain that those scientific discoveries and the latest evidence reach the patients that we see in clinic every day. Well, I actually wanted to start with a story telling you about one of these patients I met in clinic soon after joining the Penn faculty, and I think that can be done without slides. So he was in his early 70s. He had just been diagnosed with new metastatic prostate cancer that had spread to many of his bones, as prostate cancers commonly do. He had a high burden of metastatic disease and was started on what we call intensified therapy, including lifelong hormonal suppression intended to deplete testosterone, and also chemotherapy to be delivered over the course of 18 weeks. He got through chemotherapy with minimal side effects, and his cancer responded beautifully, with his PSA plummeting and many of his bone lesions scarring over. And he and I were both elated by his cancer's response. He was thrilled to have recovered from chemotherapy and to be enjoying time with his wife and his family and pursuing various avocations in retirement. And then one day, after about a year of continuing hormonal therapy, I got a call that he had fallen and sustained a major hip fracture. Interestingly, not in the area of bone with cancer, but more consistent with an osteoporotic fracture. His bones had become weakened by the hormonal therapy, and as testosterone is critical for bone health, and its depletion from our treatments can lead to loss of bone mineral density over time and increased risk of fracture. Likewise, when prostate cancer spreads to bone, especially in the castration-resistant state, men are at increased risk of various skeletal complications from the cancer itself. This fracture, this event was hugely morbid for him, including a prolonged hospitalization, post-operative recovery, and a rehabilitation that lasted several months. And overnight, I watched him become frail and a shadow of the patient that I had first met. Unfortunately, his story is not unique. Bone health, as Bob said, is critical for men on hormonal treatment for prostate cancer, with at least 20% of men suffering osteoporotic fracture at 5 years and 50% of patients with metastatic disease to bone in the castration-resistant state suffering skeletal complications, including those that require radiation or surgery. And these skeletal complications, in addition to being morbid for patients, like I mentioned for my patient, they're also independently associated with worse prognosis and survival, and they're costly, with a mean acute spend per event of at least $20,000. And what I'm here to tell you today is that we can do better. International guidelines recommend various evidence-based strategies to strengthen bones and to prevent fracture for men with prostate cancer receiving hormonal therapies. But we know that fewer than half of men for whom these therapies are indicated actually receive them. In other words, the science is not reaching the patient in practice more than half the time, and this project really aims to bridge that gap. Moreover, when we use bone-directed therapies to prevent fracture, we often clinically face a choice of two comparably effective alternatives, one of which costs $140 annually, and the other costs almost $30,000 annually. So clearly in this situation, there is a higher value alternative. And I was hoping to show you some preliminary research across the Penn system. What this preliminary research shows across the Penn system is that what are so-called behavioral nudges have been effective in promoting the use of the lower cost, higher value alternative in this case. And we borrowed this concept of nudges from other industries and disciplines such as behavioral economics, and so I suspect that many of you might be familiar with this lexicon. These behavioral nudges involve changes in choice architecture and or accountability to make doing the right thing easier for the clinician and the patient. So our objective in this project is to make the path of least resistance be the one that optimizes bone health for men with prostate cancer, thereby reducing osteoporotic fracture and skeletal complications. We are building an evidence-based clinical pathway to promote high-quality care and testing behavioral nudges deployed through the electronic health record at the point of care to motivate clinician adoption of pathway recommendations. And finally, we've proposed a pragmatic evaluation leveraging all of Penn Medicine's diverse clinical sites to evaluate the impact of this program on patients like mine, whom I introduced you to at the beginning. I appreciate your time, and I look forward to taking any questions.
Just wanted to emphasize, or maybe just ask you to tell us, so these nudges, like what would a nudge feel like? I know we use them all the time, but explain what that feels like if you're a physician.
Absolutely. The goal of a nudge is to direct a clinician, for instance, or it could be directed at a patient, in a seamless way that makes the easiest path, the path of least resistance, be the one that is, for example, in this case, evidence-based or highest quality or highest value. And so the intent is not to burden the clinician with a hard stop or a pop-up or something that interferes with their daily clinical flows, but just the opposite. It's to support them and to make seamless doing the right thing, so to speak.
So as the clinician works, maybe they go to order a medicine, they'll be prompted, choose medicine A. You can choose whatever medicine you want, but this is the easiest one to click right here. And it's driven off guidelines. Helps. It's like an autopilot, right? On flying an airplane.
It's like an autopilot. We're always preserving the clinician's ability to choose in a particular circumstance between alternative agents. Always. The clinician has the choice and has the expertise to decide for a particular patient. But yes, what it does is it favors, makes easiest the highest value evidence-based alternative. Exactly right, Bob.
Yeah, this is a revolution happening in medicine. I'm glad we're bringing it to patients with prostate cancer. So thank you, Dr. Takforian, and we'll stand by. Don't go anywhere. We're going to bring in now two other speakers. I'll introduce them both, and they're going to tag team their presentation. And they're so good, their slides are already up. The speakers are Dr. Naomi Hawes. Dr. Hawes is professor of medicine and a world-class clinician researcher in all types of GU cancers, including prostate cancer. And she's a program leader here in the Cancer Center around cancer therapeutics. And the other speaker is Trevor Penning, who's professor of pharmacology, laboratory-based investigator, biologist, and works a lot on environmental toxins as well. Trevor is also a program leader in the Cancer Center for our carcinogenesis program.
Thank you. So as you heard Bob talk today, we have a real issue when it comes to prostate cancer African American disparities. And the work I'm going to describe to you today is to address some of this disparity. Next slide, please. So to put some numbers on this, as you heard Bob say, prostate cancer is the second leading cause of cancer in men in the United States. In any year, we see about 200,000 cases of prostate cancer, leading to about 34,000 deaths annually. But if you look at the numbers for African Americans, you will see the number of cases are twice as high, and the death rate is 3 times as high. We also know that prostate cancer is dependent upon androgens, steroids such as testosterone, and the receptor to which they bind, known as the androgen receptor. And although there may be many reasons for the disparities in prostate cancer, we want to ask 2 main questions. Do African American prostate cancers make their own androgens and more than what's seen in their Caucasian counterparts? And do they have different androgen receptors? To answer this question, we definitely need, obviously, biospecimens from African Americans who have prostate cancer. I'm now going to switch to the next slide for Naomi to present.
Thank you, Trevor. So biobanks are critical in many solid tumors, but they're especially critical for some of the speakers that you have been listening to here. And what we have been able to do over the last year is to really get going on expanding. We've had a biobank, but expanding on the potential and the breadth of modern patients. So with some of the initial Cancer Center funding, what we did is we hired a technician, and we are approaching this in many different prongs. And this slide basically depicts, on the left-hand side, all of the different departments that are contributing to the biobank. So in medical oncology, Sam and Vivek Narayan and I see patients with metastatic prostate cancer. We approach those patients, and we are currently collecting blood samples on these patients, as well as, when possible, the core biopsies from their tissue diagnosis or from their previous prostatectomy. In radiation oncology, we have 5 colleagues who treat patients with radiation therapy, and these patients undergo core biopsies followed by radiation therapy and sometimes hormonal therapy. And from urology, we have patients who are considering radical or robotic prostatectomy. So we're collecting this year blood samples, but we are further developing this to also collect bone and soft tissue samples because prostate cancer often goes to the bones. And this is really a big operation where we work closely with pathology. Penn Medicine has an overall tissue procuring biobank that we're working with, but we're also collecting clinical annotation. And in the top left-hand corner here, you can see that just since September of this last year, we have 89 patients enrolled, including 67 patients who are white and 22 patients who are African American. So we're already accruing roughly 30% African American, and I think that this will be a very good source of both tissue and blood samples for looking at some of the projects that Trevor's looking at, but also it will be available to everybody in the institution, and this is a good way forward for drug development as well. So I'll hand it back over to Trevor.
So if you can bring up the next slide, please. So you heard me talk about different reasons why African Americans might be more prone to prostate cancer than whites. And we are going to be making use of the material that is coming from the biobank. So one question we want to ask is, do African Americans make more androgens in their prostate? And so we start off with a prostate tissue extract shown on the left-hand side. This could also be from advanced disease from a bone metastasis. After we make the extract, we then put it on this sophisticated instrument known as a triple quad mass spectrometer. And you can see this instrument is not cheap, about $500,000. And what this instrument is basically a very sophisticated balance, in that as it separates out the different androgens, it weighs them, and it gives us, as an output, the androgens that are present and in the amount. And if you look down, we can detect down to 1 part per trillion of any androgen in a prostate extract. This means that no androgen will go undetected, and therefore we'll be able to determine whether or not African Americans make their own androgens, and if so, perhaps by what route, which we can then target with therapy. Next slide, please. The other question we want to ask is, do African Americans have different androgen receptors? And to do this, we use another sophisticated instrument, an electron microscope that costs about $8 million. And what we do here is we take androgen receptors and we freeze them. And these receptors can be from African Americans or Caucasians. And you see these images that come up. And what we then do is use a computer to merge images from about 30,000 images to end up with a structure of the androgen receptor. And I should say at this point, no structure exists for the androgen receptor, but we also hope to see differences in androgen receptor structure between African Americans and Caucasians. And you can see in this image, we can actually see where the androgen binds, that's the testosterone, and we can see where this receptor might bind to DNA, which causes new synthesis of RNA and protein. These atomic structures of the androgen receptor will hopefully identify functional differences in African Americans and dictate different treatment plans. And so I think with these 2 projects, we are able to perhaps really address these 2 questions as it relates to African American disparity. And I thank you for your attention.
Well, thanks, Dr. Haas, Dr. Penning. And we'll ask folks tuning in to start typing their questions in the chat under the Q&A box there. And but I had a question I wanted to there. I think we're just need Dr. Khan to join the frame as well. There you go. My question for Dr. Haas, you talked about this bank, and you made a point that you're going to not only have tissues from the prostate, but also wherever prostate cancer goes, so into the bone, for example. And I wonder if you could say a little bit more about that. And what I'm driving at is this. There's lots of tumor banks, but in fact, the famous one made by the federal government is mostly tissue from surgical resections, the primary, where it first starts. But as we've started looking to where the tumor goes, it's different molecularly in terms of the local environment, the cells around. And so what are the challenges, or could you speak a little bit more about the challenges? It's not trivial to get a bone biopsy.
Sure. So the value of, first of all, the value of having metastases biopsied is that prostate cancer changes over time. And prostate cancer is especially difficult to understand and to treat because one of the favorite refuges for prostate cancer is the bone. And it has a very rich microenvironment with fibroblasts and other cells that immediately put up signs of resistance. And so one of the things that we do with the bone biopsy is we actually have 2 dedicated interventional radiologists, and we've been quite successful in this. And what they do is we bring the patients over to interventional radiology. They have a little bit of what we call conscious sedation so that they get a little bit of medicine so they're not nervous. And the area of the bone is anesthetized with a little bit of a numbing agent. And they actually put kind of a power drill into the bone, and they're able to look at this under CAT scan or MRI guidance and go right to the prostate cancer area in the bone. And we've previously been very successful in a CAR T trial where most of the patients had bone biopsies. And whereas previously prostate was very patchy and difficult to get the prostate cancer, I think we only had 1 out of 16 patients biopsied where we didn't get a biopsy of prostate cancer on the first try. And the patients have not been complaining about pain. We do a very good job of pain control with it.
Yeah, it's important to realize these sort of clinical advances, technical advances are really, really, really critical, and also how we partner with our patients who will say, yes, I consent to that. I want to be I want to join the study as well. We have a couple questions, actually several. This may be a question for Dr. Takvorian, or at least I'll ask him first. So, is an elevated PSA always seen in metastatic prostate cancer, particularly metastases to the spine? So that raises a good question of, tell us a little bit about PSA, what it's useful for, what it's not useful for, and other thoughts you might have about that question.
Absolutely, that's a very good question. The short answer is that most of the time, for patients who are presenting with either recurrent or new metastatic prostate cancer, for example, to bone, they will present with an elevated PSA, but it's not always the case. And in fact, for those men that present with metastatic disease, meaning spread of the prostate cancer from the prostate to other areas of the body, in the context of a low PSA or a normal PSA, that is often a predictor or a harbinger of worse, more aggressive, more de-differentiated disease, bad disease, basically. So that's a short answer. The PSA often can be a biomarker of disease activity and disease burden, but not always.
Yeah. It's turned out to be pretty tricky. We use it, but it needs interpretation. Dr. Penning, question from Chris Hall. Maybe you can see it there. Do we know if there is a receptor disparity between Caucasians and Black men? Or is that just a hypothesis that you have at the moment? So do we know that to be true, or is it something you're working on? And could it be?
So there is evidence in the literature that there is a difference in the structure of the androgen receptor in African Americans versus men, but we don't know what that does to function, which is why the structure is important.
Yeah. Chris points out that there is obviously another dimension to health inequity in prostate cancer, which relates to disparate medical resources that delay detection and treatment. I know Sam is thinking about those questions too. No question. And I think it takes, we need a biological approach, socioeconomic approach. And Naomi, jump in. Yes, Dr. Haas.
So I just wanted to add that one of the reasons that Trevor is working on this field is that there have been observations in African American and Caucasian patients treated with abiraterone that there are actually, so these are groups of people where everybody's getting the same support and everything, and there's an increased responding to abiraterone in the African American population. So that sort of is another direction that piqued our interest in looking at the function of the androgen receptor, because you could actually look at people getting the same treatment the same way and see that there were some differences in outcome.
Yeah. I want to bring Dr. Khan in on another question here, which has to do with the role of breakthrough bike challenge funding. So Tony Wells asks, are all these projects funded by BBC? They are. All of you are Cooper scholars. Crystal is relatively new in starting your lab, and so could you tell us what the power of this funding has been for you?
Of course. Thank you again for supporting us with our research. So as mentioned, I started my lab at the beginning of 2020, at the start of the pandemic, and this support has really allowed me to get my lab up and running, even during the pandemic, in order to get basically the resources I need and to push forward some of the sequencing I'm doing in order to identify that adaptive proteome. Some of the things that we might be able to see in that data, for example, is going to be the AR and how the AR, the androgen receptor, is actually, creating unique isoforms or variants as well. And we already know that happens in patients as the disease metastasizes. But for me to get the lab up and running and have that data source, I couldn't have done it without the support that I get through the Aberson Cancer Center and also through BBC. So thank you.
Let's drill into that a little bit. So you're beginning to get data that is from experiments funded by BBC. So then the next step for you would be to write another grant, a bigger grant. So do you have plans to do that? I'm putting you on the spot. Speaking to the microphone.
Yes, of course. So the goal is always to use preliminary data to grow into a larger grant. And of course, working with our peers here, working on prostate cancer, I can be able to talk to Naomi and Trevor and Samuel and talk about how can I utilize some of the biobank, for example, to look at these unique isoforms I'm finding. And I can propose all of that for grants. I'm hoping to submit a variety of them this fall. And then early next year, hopefully be submitting an R01, which is for the research labs. It's kind of what helps fund us for years, and in order for me to also support my staff and the researchers who I train, including undergraduate summer students all the way up to postdocs and even MD fellows in the lab, to teach them these techniques and what it means for translational medicine for patients.
Yeah, we've talked about this before. I know when we've gotten together for increasing cadence sessions, how a pilot grant, you may look at those dollars, but then it allows you to generate data that you then get a larger grant. That R01 you talked about, that's a $2 million grant. So just think about the return on investment and how $1 donated to BBC can turn into, $10 more dollars in the right hands with smart scientists like Dr. Khan. There is a question, let me find it. It was a great question about what does this crowd think will likely be the next breakthroughs in prostate cancer? What about immunotherapy? Something else? And when can we expect that? So all of you can give your perspective.
So I will go first, Bob. So we talked about changes in the androgen receptor. What happens as the disease progresses, you get what we call splice variants, where they lose their ability to bind the androgen but remain active. And so what we need are new therapeutics that will target the splice variant. And we can do that if we have structural information on the androgen receptor.
Absolutely. We're not, I mean, I think the point there is we're not guessing on new medicines anymore. It's science driven. Just as Dr. Khan told us, let's find the roadmap and then we can drug it. Naomi, what are your thoughts on that really great question?
So, from the biobank perspective, and from prostate cancer in general, I think that there are several approaches, but I think it's going to be not just one thing that breaks through, but a combination of things. So, some of your previous speakers, I think Kara Maxwell was a breakthrough bike challenge last year, is looking at precision, looking at differences in gene expression between like germline mutations and also how things differ in metastatic disease. And so we know that different patients with prostate cancer have different pathway-driven disease. PTEN is an important mutation with bad prostate cancer. The CDK pathway is another pathway that's being looked at. So I think that what you're going to find is prostate cancer is going to be not just one disease, but a collection of different diseases. And that we're going to use these different tools in the toolbox, immunotherapy, but also new targets, what Crystal is identifying with proteomics, and also looking at these things earlier and earlier, so that if we can identify people at higher risk or patients who present with prostate cancer who have really bad disease in their primary tumor, that we have more personalized therapy towards those patients.
Yeah, I think the track record is there. I mean, I think back to when I was a fellow, how many drugs we had to treat patients with advanced prostate cancer, really not that many things. And over the last 10, particularly 5 years, Naomi, the FDA approvals that are coming in, the choices, there's many, many more, and they're effective, they're less toxic. So there's a lot of advances, I think. Would you agree with that?
Yes, and I just wanted to say also that the Breakthrough Bike Challenge has allowed us to hire a second research coordinator so we have one that collects specimens at the Perelman Center. We're now going to be able to do this at Presbyterian Hospital, and that person is going to run the half mile or 3/4 of a mile from Presbyterian with these samples over to Penn. So the money that you gave us has allowed us to really double the size of the program.
I love that incredibly practical explanation for what support means. Of course, Penn Presbyterian, a key part of Penn Medicine, one of our 6 adult hospitals, has a very large prostate cancer program at its cancer center, Abrams Cancer Center, based there. And connecting, we have the geographic problem. It's about a 20-minute walk away. So we want to work as a system, not just one hospital, but as 6. And that's a great example. A couple other questions. Let's stick to, I wanted to hear some thoughts on immunotherapy and prostate cancer. Crystal mentioned the PD-L1 aspect, which was pretty cool. But what's available in terms of immune therapy right now for this disease?
I guess that's me to answer. So there are 2 different directions that are being looked at. One is what we call antibody therapy, where we're working with immune checkpoint inhibitors and we're, again, taking off the brakes of the immune system. And the other is called adoptive cell therapy, and that's where we engineer some of the lymphocytes, T lymphocytes that patients have in the body, and direct them to go after the cancer. And these are both areas of high interest. The Parker Institute has funded some trials that we're participating in that combine ipilimumab and nivolumab, which are immune checkpoint and CTLA-4 inhibitors. And then we work with Carl June with the CAR-T program, and there are different approaches in adoptive therapy. There's TIL cells, there's TCRs, and there's CAR-Ts. What we do is we use part of the immune receptor that's important in the T cell, and then we make modifications to that, and we can hook different things like antigens that target things. For example, we're doing one targeting prostate-specific membrane antigen and transforming growth factor beta, and we put both of these, attach them to a modified T cell receptor, put that into a T cell with using a virus, harvest the patient's T cells, infect their T cells with this new engineered thing, and then we give it back to the patient, and it's kind of a personalized therapy where we direct the patient's T cells to go after their prostate cancer. There's also bispecific antibodies, and those are things we're participating in as well. And those are T cells coupled, one Bob can probably explain this better, but coupled to different immune drivers and then to a selected target in the like PSMA, for example.
Yeah. And Naomi, to your credit for being a national leader on so many of these efforts, particularly the CAR T cell, this was transformative for patients with certain types of leukemia and lymphoma, and now we hope to do it in prostate cancer. It's an interesting historical point that the first FDA-approved drug in modern times, at the start of the immune revolution, was for prostate cancer. It was a vaccine. It didn't, we thought it was great, but then we saw other therapies that work a lot better, so it's since been more or less replaced. There is a question I'll just refer to, about white cell counts dropping in reply to therapy. It happens, particularly chemotherapy, and all types of cancer treatments. This is a problem, and the more we use immune therapy, of course, we don't want to use other therapies that destroy the immune system at the same time. So that's always a challenge. It's a good question. There are a few other things I'll address. Some of them are about the program. So, but before we get to that, there's a question from Bill. Are there any African American doctors and clinicians in the department? So this is a fantastic question. So across the country, and we are no exception, the field of oncology is poorly represented with physicians who are Black, and we're particularly in the last year, redoubled, should I say, quadrupled efforts to recruit and train such individuals. And we've had some success there with new faculty joining us, not necessarily prostate cancer, but in neuro-oncology and neurology and breast cancer and other areas in the basic sciences. I would say it's a critical issue. And the problem is at the level of the physicians. Not problem, but the disparity is at the level of physicians. Our staff, much more diverse. And so we're focusing on, as much as we want to recruit, we actually want to encourage more scientists, more physicians who are Black to enter hematology oncology. And so we're actually reaching back to college programs, to medical school programs, high school programs, to encourage more folks to be interested in this work, particularly because there are remaining across cancer so many Black-white disparities. It's important that we have a faculty that represents the community that we serve. So much more work to be done. I'm glad, Bill, that you brought it up. We only have 5 more minutes. I do want to mention one final thing here that, we have a question from Bo, and then I'll come to Christina's question. Let me just flip the order. So, Bo, And we thank Bo for all his hard work and leadership on BBC. He asked about TIL therapy. Is TIL therapy patient specific? That is, can it be done on a broad scale and applied from patient to patient? Tumor infiltrating lymphocytes is what TIL stands for. These are not the engineered T cells. There's another way of doing it, and they tend to be made from the same patient. So it's often a limitation that you have to grow those cells from the patient you're about to treat. It was one of the reasons that when we switched to more genetic modifiable, because it was more reliable to do that. We could more reliably direct the cells, and that was Carl's hypothesis, turned out to be correct. But a lot of people still working on TILs. They're powerful. There are some efforts now to understand universal TILs, universal CAR that would apply across patients. That really puts us up against some major immunological barriers, but we've done remarkable things in the past. So that's coming, Bo, and it's still in development. Final question I'll just say is, tell us about the Buzz Cooper Scholarship Fund. How are the research projects chosen? It's a great question. That's done at the level of the Cancer Center. So we partner with the BBC board, as you know. We talk about priorities over the years. We've chosen different priorities. We always get feedback on our ideas from the board, and you've been great advisors. For example, we talked about focusing on prostate cancer this year, and you readily endorsed, for all the reasons that we've heard about today, the need and other issues. We then asked for proposals, and this is peer-reviewed. We have a grants committee. It's chaired by Kate Nathanson, who's deputy director of the Cancer Center, and proposals are brought in, and they're vetted by other members of the Cancer Center. Sometimes we get outside expertise, and they're scored. And we look for the best science, the most feasible work, where we'll have the greatest impact. And the committee votes and decides, and then a notice of grant award, we call it, is provided. Sometimes we're able to add more money to a particular award because we have maybe another grant that's related, and we can pull things together. So we always try to leverage wherever we can. The bottom line to your question, Christine, is that we choose the best science, the best scientists, that we're looking for high impact. If it's risky, that's okay. Because we're looking, this is breakthrough bike challenge. So that's what we're all about. We're not about incremental. It's not the incremental bike challenge, breakthrough. And that's why we work at the Abramson Cancer Center. And I think you've met 4 individuals who personify that. We're at the close of the hour. I won't go 1 minute longer. I want to do 2 things. First, thank all our faculty participants, Trevor, Naomi, Sam, and Crystal. I'm calling them by their first names like I usually do now that we've had an hour of getting to know each other. Thank you all for participating, your great creativity. Just remarkable. Thank you again and again. And then to all of you who joined in and spent some time with us today, thank you. Thank you for being out there, being our advocates, being our ambassadors, partnering with us in this exceptional way. We're coming close to 10 years of being partnered with the Breakthrough Bike Challenge. It's a signature event every fall. We love it. We're looking forward to it again this year, September 12th, at least virtual, possibly hybrid. We're staying tuned, watching the world. So salute to you. I think you heard some very real examples of how powerful the support can be, both in terms of dollars and just your support, knowing that there's people out there supporting our work. With that, we'll say good day and start training. We need you biking, walking, spinning, and you'll hear more from us on that in the BBC board quite soon. Have a great day. So long, everybody.